The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Patrick Kraft here to review the management of all things trauma, resuscitation, and adjuncts.
Hey, Jose, it's great to be here. Thanks for having me. Looking forward to a great podcast.
Of course. Dr. Kraft is a trauma surgeon at Washington University in St. Louis. My name is José Aldana, and I'm a general surgery resident, and I will be your host for this episode. Trauma resuscitation is a high-yield topic. Trauma is a leading cause of death and disability around the world, especially among young people. Whether you are in a small community hospital or a big academic center, you will be taking care of some level of trauma. Today, we will learn how to assess and resuscitate trauma patients using guidelines established by the Advanced Trauma Life Support, or ATLS. Let's dive right into a case scenario to guide our discussion.
Okay, so first case is going to be a 24-year-old male patient, no significant past medical history, that arrives to your ED as a level 1 trauma after a rollover MVC at 60 miles per hour. Patient was restrained, there was airbag deployment, blood pressure is 120/80, heart rate of 100, SAT of 95% on room air, and a GCS of 15. Estimated time of arrival is 5 minutes. What are your thoughts about possible injuries of this patient and how you want to prepare the team for the trauma?
Okay, so this is a polytrauma patient. We'll be concerned for a TBI, traumatic brain injury, blunt chest or abdominal trauma, and some fractures. To prepare for the trauma, I will assign roles in the ED. All the team should be wearing PPE. I would like to have an endotracheal tube, blood and chest tube, and chest X-ray and ultrasound available in the room.
Okay, so it sounds like you're getting the team prepped. It's very important, talking about potential scenarios and getting everyone ready to accept this patient. So the patient arrives. How would you initially assess them?
Since the patient is stable, I would like to wait for the EMS report. Subsequently, I will proceed with a primary survey per ATLS. The assessment is a systematic, rapid evaluation of immediate threats to life. The ABDCE mnemonic is as follows. A for airway with cervical spine control. Here, I would like to see the patient that can respond verbally in clear voice. Also, if patient is not responsive and GCS is less than 8, I would like to perform an intubation using the rapid sequence intubation. Once the endotracheal tube is placed, I would like to check for capnography, listen for breath sounds, do a chest X-ray, and also determine sedation and analgesia plan. For B, breathing and ventilation, every trauma patient should have oxygen administered and also a pulse oximeter placed. I would like to check for signs of dysfunctional breathing that include abnormal or unequal breath sounds, accessory muscle usage, or abdominal chest or abdominal chest wall motion. In the unstable patient, the treatment should be immediate and not to be delayed for imaging studies. I will also would like to place a patient on a monitor with a pulse oximetry and supplemental oxygen. C, that stands for circulation and hemorrhage control. We need to assess for vital signs, mental status. On physical examination, we assess for capillary refill, pulses, temperature. With the placement of a Foley catheter, we can measure the urine output, and this can be used to assess circulation and also guide our resuscitation. We need to ensure that the patient has adequate vascular access to promptly initiate resuscitation if needed. And very important, we have to guarantee peripheral access with 2 large bore IV lines, either a 14 or 16 gauge, or maybe an intraosseous access, or maybe a central line. D, for disability, we assess the Glasgow Coma Scale, or GCS, which is a clinical tool to quickly assess a patient's level of consciousness following a traumatic injury. The scale goes from 3 to 15 And we give 4 points for eyes opening, 5 points for verbal response, and 6 points for motor response.
What GCS is going to be our cutoff?
Our cutoff for intubation is going to be GCS equal or less than 8.
Okay, great.
And also, we need to perform a neurologic examination, including pupillary changes, loss of sensory and motor function. And lastly, for E is exposure and environmental control. Here, we have to make a complete visual inspection of the patient, roll the patient while maintaining a spinal stability, also splaying of the legs to examine the perineum and elevation of the arms to inspect the axilla. In penetrating trauma, ballistic injuries should be counted and positions noted. And for environmental control, we should minimize heat loss in exposed trauma patients. So we need to keep the resuscitation room warm, cover the patient once survey has been completed, and all resuscitation fluids should be warm.
Yeah, so a lot to unwrap there. I think that the thing to really stress is that it's a systematic approach each and every time to the trauma patients, and although these are the mnemonics, the A, B, C, D, E, a number of these things, just because you have such a large team involved, a number of these things are going on simultaneously. So just sticking with a systematic approach each and every time ensures that you don't miss anything with your trauma patients. Okay, so going back to the trauma bay, this patient's airway is intact, bilateral breath sounds present, slight diminished breath sound on the left, central and peripheral pulses are present, symmetric. GCS is 15, the pelvis is stable. You do note a seatbelt sign on exam. So Jose, let's say this patient was mildly hypotensive and you're concerned for shock. What types of shock and what's the most common type that we normally encounter?
Okay, so in trauma, we see hemorrhagic shock, cardiogenic shock, and neurogenic shock. Being hemorrhagic, the most common one, occurs as a result of a decreased intravascular volume secondary to hemorrhage. Hemorrhagic shock is a presumed etiology of hemodynamic instability in all trauma patients until proven otherwise, and there is a classification depending on the estimated blood loss and hemodynamic changes. So to make it just brief, class 1 and class 2, these patients they have an estimated blood loss from 700 to up to 1,500 cc's, which represent from 15 to 30% of the blood volume. And these patients are stable and they could have maybe elevated pulse rate or tachycardia. And other than that, the blood pressure should be normal and the pulse pressure and urinary output could be diminished. For class 3 and class 4, where there's an estimated blood loss from 1,500 up to 2 liters or more, which represent 30% or 40% of the blood volume or more. Here we can see some hemodynamic instability, so the pulse rate definitely elevated above 120, 140, and blood pressure, pulse pressure, and urinary output significantly decreased.
Yeah, and I think that's the good point that you make there too. That transition from 2 to 3, where you start to go from 1,500 to 2 liters of blood loss, you start to really see those hemodynamic changes. You're going to see an increase in the blood or an increase in the heart rate, drop in the blood pressure. And then as you go even further, you start seeing the anxiety that comes with the hypotension and impending shock. So those are great points.
It's worth to mention the term of permissive hypotension, which consists of allowing the patient's systolic blood pressure to be around 80 and 90. This has been proven to increase survival in the trauma patients. And also the early resuscitation with blood products that prevent dilutional coagulopathy that treats intrinsic acute traumatic coagulopathy. You can also take a better look of it in the Washington Manual of Surgery. Yeah,
so ideally we're replacing bleeding with blood and not saline, crystalloid. There's another number of studies out there, a little controversial still for some, but I think it's moving in this direction that whole blood is the best way to resuscitate these patients. So more to come on that in the coming years, but hopefully I think that data is going to support use of whole blood. Okay, so back to our patient in the trauma bay. Knowing that the patient has diminished breath sounds on the left side, what are some adjuncts you can use to make your diagnosis, and what are you worried about?
So the adjuncts that we can use, initially I will say chest x-ray. We have to keep in mind that this should not delay patient treatment. If warranted based on mechanism and presentation, with the chest x-ray, we can assess for a position of an intratracheal tube if placed. And for this patient, I will be concerned for either like a pleural effusion, in this case, since it's a trauma patient, for a hemothorax or also a pneumothorax. But also we can check for any diaphragmatic injury. For the other adjunct that we use in the trauma bay is a focused assessment sonography in trauma, or FAST examination. This is a non-invasive way to identify hemorrhage using a bedside ultrasound, and helps to triage whether the patient should go to the OR, to a scan, or to an angio suite. The FAST examination is particularly important in the unstable blunt trauma patients, for the identification of free fluid of these patients, and this will warrant these patients to be or take these patients to the OR.
That's a great point. The FAST is particularly useful in those patients that come in with a blunt traumatic injury and they're unstable, trying to determine or not whether they have some type of intra-abdominal hemorrhage or other intrathoracic injury. It's very helpful to do that. So what are some other uses for the ultrasound?
So in the FAST, we look for the pedicle sac. Here we can see for tamponade, wall motion abnormalities in the splenorenal fossa, hepatorenal fossa, and pelvis or pouch of Douglas. We'll look for fluid, which in this case should be blood.
All right, so your chest x-ray, you get your chest x-ray, it shows absence of lung fields. You suspect a medium-sized pneumothorax just based on your imaging. Ultrasound confirms the same.
So in this case, I would like to proceed with a left thoracostomy tube placement. Since the patient is able, I would like to get consent or discuss the reasoning behind this decision and get patient consent. For this, I would like to position the patient in a semilateral decubitus position. We should identify the safe triangle for the chest tube placement, which is marked by the lateral border of the pectoralis major muscle and the anterior border of the latissimus dorsi muscle and the level of the nipple of inflammatory fold. We are going to make a transverse incision through the skin and subcutaneous tissue and bluntly enter the pleural cavity with a curb clamp. It is important to direct the instrument over the top of the rib to minimize the risk of injury to the intercostal neurovascular bundle. Then we proceed to insert the thoracostomy tube through this tract and direct it superiorly and posteriorly.
And just prior to you doing that, you're gonna put your finger in the chest cavity, ensure there's no lung adherent to the wall, and that you're in the right space.
Correct. Yep, that's right. Then when the tube is positioned, we secure it properly, and then we're gonna connect it to an underwater seal suction device, and proceed with a chest X-ray just to check for lung re-expansion and the position of the tube. Post-tube placement, I will encourage the patient to use the speedometer and also for adequate pain control.
Great. So you've got your chest tube placed. Now let's talk about a situation in which, the patient, say you're not able to get the chest tube placed soon enough, or the patient has a cardiac arrest as EMS is bringing the patient into the trauma bay. How would you want to deal with that situation?
So in this case, I would like to perform a resuscitative thoracotomy.
Okay, resuscitative thoracotomy, you bring up a good point there. There's really two patient populations, and that really determines your algorithm for that. So the two being penetrating versus blunt. So why don't we talk a little bit first about the penetrating trauma? What patients are going to be candidates there?
So for penetrating trauma, the indications are witness arrest during resuscitation, pulseless, and only have received cardiopulmonary resuscitation for less than 15 minutes.
Right. So these are the patients that EMS brings in from the field. They either have coded and they've been doing CPR for up to 15 minutes. Anything over than that, the salvageability on those patients just doesn't support performing the thoracotomy. And then, of course, anybody that's less than 15 minutes that has an arrest witnessed in the trauma bay, those are definitely patients that are salvageable and you want to perform the thoracotomy on. Now, how about for the blunt trauma? So we know that just based on the mechanism of injury in those patients, we are a little bit more conservative doing the thoracotomy. So what patients would you want to do this on, and who would you want to stay away from doing so?
So for contraindications, no signs of life at scene of trauma, prolonged pulselessness, more than 5 minutes, non-survivable head injuries or definitive injury management cannot be addressed. Yeah.
So if this patient's down, they're doing CPR at the scene more than 5 minutes, this is just not going to be a salvageable situation. You also mentioned bad head traumas, and then if you can't get the patient to definitive injury management to the OR, then that's not going to be a situation where you want to do a thoracotomy. So why don't you just walk us through how you would perform that resuscitative thoracotomy?
Yeah, so for the resuscitative thoracotomy, I would like to start positioning the patient supine with the left arm elevated and then perform a left anterolateral thoracotomy at the fifth intercostal space from the left sternocostal junction to the latissimus dorsi muscle.
Yeah, and once you get your rib space open, you're going to put your Finicetto spreader in there, get the ribs opened up, and hopefully you've got a couple assistants that are helping you out here. What next?
So next, we're going to elevate the left lung medially to locate and dissect the descending aorta and place a vascular clamp across it. If cardiac injury is suspected, we proceed to open the pericardial sac and evacuate any blood clots and identify any cardiac lacerations. If there's an active bleeding in the pulmonary hilum, apply a vascular clamp across it. And once all the injuries have been temporized, we proceed immediately to the operating room for the definitive management.
Yeah, and the whole purpose of cross-clamping the aorta is to what?
Is to maintain and keep blood flow through to the brain.
Yeah, so trying to preserve that blood flow to the brain while also getting hemorrhage control of whatever the injury may be distal. All right, great job.
Thank you, Dr. Kraft, for being with us today. We got through a ton of great information about resuscitation in trauma and adjuncts.
Yeah, thanks for having me. It was a great show. We covered a lot of great information today.
And as always, if you're looking to learn more, you can check out some of the literature about this topic in the show notes, and a full review of it can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.